of someone we want to pre-oxygenate, but he's not letting it happen. He's fighting us, he's ripping off the mask. And he might be agitated due to septic encephalopathy, or maybe it's hypercapnia, or maybe it's the hypoxemia itself. But for whatever reason, you're going to have patients who are not going to cooperate. So what do you do when they have a low saturation, but they won't tolerate your preparations? Well, the classic answer, the board exam answer, would be to move to immediate rapid sequence intubation. And there's a lot of advocates even right now for this being what you should do. I just got a letter to the editor about an article I'm going to tell you about saying this thing I'm going to tell you about called DSI is crazy. What we should be doing is RSI and actually sticking with the standard paradigm. But in my mind, that's always been gambling. What you're gambling if you push your rapid sequence intubation meds on a patient like this is that you're going to be able to bring their saturation up during the apneic period, because 80% is a really bad place to be. I don't like gambling. I like to know exactly what's going to happen to my patient minute by minute as I'm managing them when they're critically ill. But what they're talking about really isn't RSI, because RSI would have you giving your induction med, giving your paralytic, and then leaving that apneic period without any positive pressure breaths. So what they're really talking about is a modified RSI. And this modified version of RSI, where you're actually bagging a patient during an apneic period, is somewhat dangerous. Now, I have no problem with people like my friend Rich, who give 2 or 3 gentle, perfect breaths during the apneic period. That's just a bonus, and that works out quite nicely. But that's not usually the way I see it happening. When you have a patient whose saturation is already 80%, you crash push your intubation meds, and then you start bagging them hoping it's going to come up. It's a little different in those circumstances, and there's a tendency to squeeze hard and fast, cause gastric insufflation, and then once the patient vomits, it all goes downhill. This patient at 80% sat is about a few seconds away from dropping down to 70. And 70% is the critical desaturation point at which the risk of peri-intubation arrest becomes really, really high. And then there's another issue, and I talk about it on the podcast, pulse ox lag. This patient at 80%, as you're bagging, will not, if he's sick, come up from that 80%, even if your breaths are going in. In the best of circumstances, the pulse ox represents where the patient's saturations were 30 seconds in the past. In critically ill patients with poor cardiac output, it could be up to 2 to 3 minutes. So even if they're doing a perfect set of respirations with their BVM like Rich would, as that sat doesn't get any better, the natural inclination of our monkey brain is to bag harder and faster. And I promise you, in many of these circumstances, these patients are going to get gastric insufflation and be at risk of vomiting, or I should say passive regurgitation. So when I had seen enough of these patients, I'm sorry. Guys, let's play video number 1. The one other thing is bagging a patient with physiologic shunt like this guy at 80 on a non-rebreather won't work anyway. This is George Kovacs' video. You can see that was a standard BVM. It didn't do anything to inflate that lung. Now look at this. With a PEEP valve on, yes, the lung will inflate. But I so rarely see people actually getting the PEEP valve. So what they're going to advocate is bagging this patient at 80% on a non-rebreather up during the apneic period. There's no way that's going to have any good effects on this patient's oxygen saturation. So to combat all of this, I came up with a concept called delayed sequence intubation. It breaks the sequence of RSI, and it gives you an option, I think, to actually safely manage these patients who are not letting you do the things you want to do in the pre-intubation period. So delayed sequence intubation is a way of accomplishing all of these tasks that we should be doing for every single patient we intubate. Denitrogenation, pre-oxygenation, perfect positioning. If the patient needs it, they're a GI bleed, they're a small bowel obstruction, gastric emptying, and then perhaps most importantly, team briefing. And when it's a crash intubation, when you're forced to move, you don't get to do these things. But delayed sequence intubation now gives you an opportunity even in the agitated patient. So what is it? You have a patient who's delirious, who's fighting you, they're agitated, so you dissociate them. You give them a medication that will immediately calm them down, but will maintain airway reflexes, will maintain respiratory drive. And the prototypical agent for that is ketamine. my favorite medication in the world. And if you give ketamine at reasonably small doses in a sick patient, they will very rapidly dissociate. The doses we recommend, 1 milligram per kilogram, which sounds low. People might be used to higher doses. Try the 1 milligram per kilogram and see the response. You will see the full results of ketamine within one circulatory time, within seconds. So there's no reason to give huge doses because there's dose-dependent side effects to this medication, like hypersalivation. So give a milligram per kilogram of the ketamine. Wait a few seconds. The patient should fall back on the stretcher, eyes goggling back and forth, not fighting you at all anymore. If it doesn't, if that's not enough, give another 0.5 milligrams per kilogram. Wait a few seconds. Do it again if you need to. But eventually you'll get the patient to the point where they are dissociated. At this point, you could pre-oxygenate. You could denitrogenate. You could put an NG tube in if you want. You could do all the things you want to do to get ready calmly and safely. And only at that point, after the patient's denitrogenated for 3 minutes, after their saturations have come up, push your paralytic agent, give apneic oxygenation during the apneic period, and then intubate them safely with a buffer of oxygen as a reservoir in their lungs. Delayed sequence intubation is not CPAP pre-oxygenation. You don't need to put the patient on non-invasive or give them PEEP in order to be doing DSI. In fact, many of the patients in the study I'm going to show you in a minute actually they were saturating okay, but they wouldn't tolerate the non-rebreather mask in order to wash out the nitrogen of their lungs. So DSI is not CPAP pre-oxygenation, but DSI works beautifully with CPAP pre-oxygenation for patients who are physiologically shunted and their saturations are not coming up with the standard pre-oxygenation techniques like a non-rebreather mask. These four concepts are the things I've been talking about for years now, and they all work very nicely together. And we've belabored apneic oxygenation to the point you don't need to hear about it anymore. We're talking about DSI and CPAP pre-oxygenation right now, and using a ventilator as a better bag may be a topic for a future smack talk. So let's say on this patient, they're showing us that a non-rebreather is not enough to get their saturations up. How should we apply CPAP for pre-oxygenation? In the old days, I would have said just get a ventilator, have respiratory, keep ventilators in your resuscitation bay so that you could just immediately turn it on and put the patient on PEEP through the ventilator. But having actually road tested that with a host of people at many, many different institutions across the world, I realized that probably is not the safest way to go. It works beautifully, but it adds a level of technical expertise and possible error that's probably not worth it. I don't recommend that anymore. These CPAP devices, great, but you might not have them, you might not know how to use them. Don't do it. Grab a nasal cannula. If you're somewhere in the UK, you could grab a Mapleson circuit. I make my own, and all I say is get a PEEP valve. If you don't know what these are, your respiratory therapy department or your hospital stocks these. Every hospital in the world has these. They're dirt cheap, and they fit on the exhalation port of every BVM out there, and they allow you to dial in whatever PEEP you want. If you put a nasal cannula underneath the mask of that BVM with a PEEP valve, it becomes a high-flow CPAP device that will allow the patient to have whatever PEEP you dial in, regardless of whether they're breathing or not. So on a patient you're doing DSI on, put on a nasal cannula,